Acls, Advanced Cardiac Life Support, Acls Guidelines, Principles of Management, Excellent Basic Life Support and its Importance, Excellent Cardiopulmonary Resuscitation, CPR, and Early Defibrillation for Treatable Arrhythmias. In the past, clinicians frequently interrupted CPR to check for pulses, perform tracheal intubation, or obtain venous access. Current Acls guidelines strongly recommend that every effort be made not to interrupt CPR, other or less vital interventions. Studies in both the in-hospital and pre-hospital settings demonstrate that chest compressions are often performed incorrectly, inconsistently, and with excessive interruption. A single biphasic defibrillation remains the recommended treatment for ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT. Patients are often overventilated during resuscitations, which can compromise venous return, resulting in reduced cardiac output and inadequate cerebral and cardiac perfusion. Resuscitation team management. 2 principles provide the foundation for CRM, leadership and communication. The team leader should avoid performing technical procedures. In CRM, communication is organized to provide effective and efficient care. A good team leader enlists the collective wisdom and experience of the entire team as needed. Initial management and ECG interpretation. In the non-cardiac arrest situation, the other initial interventions for ACLS include administering oxygen. Stable patients require an assessment of their electrocardiogram in order to provide appropriate treatment consistent with Acls guideline. Such an approach is guided by the following questions. Is the rhythm fast or slow? Are the QRS complexes wide or narrow? Is the rhythm regular or irregular? The answers to these questions often enable the clinician to make a provisional diagnosis and initiate appropriate therapy. Airway management while performing ACLS. Ventilation is performed during CPR to maintain adequate oxygenation. The elimination of carbon dioxide is less important. Normalization of pH through hyperventilation is both dangerous and unattainable until there is return of spontaneous circulation, or OSC. The ventilation rate is determined by whether the patient is intubated. It is widely believed that a lower minute ventilation is needed for patients in cardiac arrest. Taking these principles into account, the Acls guidelines support the use of a bag mask device or a blindly placed supraglottic airway for ventilation. A blindly inserted supraglottic airway can be placed without interrupting chest compressions, provides adequate ventilation. Advanced airway management using a supraglottic airway or tracheal intubation may not be the best approach for managing cardiac arrest patients in the pre-hospital setting. Patients managed in the pre-hospital setting with bag mask ventilation had significantly higher rates of neurologically intact survival. If advanced airway management is to be performed at all in pre-hospital cardiac arrest patients, it must be done by competent provider. The Acls guidelines include the following additional recommendations about airway management during the performance of ACLS. Sudden cardiac arrest. Ventricular fibrillation and pulseless ventricular tachycardia. The most recent version of the AHA algorithm for the management of cardiac arrest can be accessed. Excellent cardiopulmonary resuscitation, CPR, is performed. Begin performing excellent chest compressions as soon as sudden cardiac arrest, SCA, is recognized and continue while the defibrillator is being attached. In the case of a witnessed cardiac arrest, perform defibrillation as quickly as possible. Biphasic defibrillators are recommended because of their increased efficacy at lower energy levels. The Acls guidelines recommend the resumption of CPR immediately after defibrillation without rechecking for a pulse. Basic Life Support, BLS, in adults, section on defibrillation. If VF or pulseless VT persists after at least one attempt at defibrillation and 2 minutes of CPR, give epinephrine, 1 mg for every 3 to 5 minutes, while CPR is performed continuously. Evidence suggests that antiarrhythmic drugs provide little survival benefit in refractory VF or pulseless. Amiodarone. 300 mg 4 with a repeat dose of 150 mg 4 as indicated, may be administered in VF or pulseless VT unresponsive to defibrillation, CPR, and epinephrine. Lidocaine, 1 to 1.5 mg per kilogram 4, then 0.5 to 0.75 mg per kilogram every 5 to 10 minutes, may be used if imiodarone is unavailable. Magnesium sulfate, 2G4, followed by a maintenance infusion, may be used to treat polymorphic ventricular tachycardia, refractory VF or pulseless. It may be caused by an acute coronary syndrome, ACS, in which case percutaneous coronary intervention can be performed. The ROSC in VF and pulseless VT hinges on early defibrillation and excellent CPR. Asystole and pulseless electrical activity. In the Acls Guidelines, asystole and PEA are addressed together because successful management for both depends on excellent CPR, also depends on vasopressor treatment, epinephrine, and rapid reversal of underlying causes, such as hypoxia, hyperkalemia, poisoning, and hemorrhage. Treatment for asystole and PEA consists of early identification and treatment of reversible causes and excellent CPR with epinephrine administration until either a ROSC or a shockable rhythm occurs. Monitoring. Data. Bradycardia. Bradycardia is defined conservatively as a heart rate below 60 beats per minute. Administer atropine, if easily done, and immediately prepare to treat the patient with transcutaneous pacing or an infusion of a chronotropic agent, dopamine or epinephrine. The initial dose of atropine is 0.5 mg 4. This dose may be repeated every 3 to 5 minutes to a total dose. Before using transcutaneous pacing, assess whether the patient can perceive the pain associated with this procedure. Transvenous pacing. Common toxicologic causes of symptomatic bradycardia include supratherapeutic levels of beta blockers, calcium channel blockers, and digoxin. Tachycardia. Tachycardia is defined as a heart rate above 100 beats per minute. The fundamental approach. First, determine if the patient is unstable. If instability is present and appears related to the tachycardia, treat immediately with synchronized cardioversion. In the stable patient, use the electrocardiogram, ECG. 3 questions provide the basis for assessing the electrocardiogram in this setting. Is the patient in a sinus rhythm? Is the QRS complex wide or narrow? Is the rhythm regular or irregular? Regular narrow complex. Supraventricular tachycardia, SVT, is irregular tachycardia most often caused by a reentrant mechanism within the conduction system. Because of its extremely short half-life, adenosine, 6 to 12 mg IV, is injected as rapidly as possible into a large proximal vein, followed immediately by a 20 ml saline flush. Prior to injection, warn the patient about transient side effects from adenosine. If conversion attempts fail, initiate rate control with either an intravenous non-dihydropyridine calcium channel blocker or a beta blocker. Irregular narrow complex. Irregular narrow complex tachycardias may be caused by atrial fibrillation. The initial goal of treatment in stable patients is to control the heart rate using either a non-dihydropyridine calcium channel blocker, or verapamil or a beta blocker. Calcium channel blockers and beta blockers may cause or worsen hypotension. Diltiazem is suggested in most instances for the management of acute atrial fibrillation with rapid ventricular response. Cardioversion of stable patients with irregular narrow complex tachycardias. Should NOT be undertaken without considering the risk of embolic stroke? Regular wide complex. Irregular wide complex tachycardia is generally ventricular in etiology. In cases of regular wide complex tachycardia with a monomorphic QRS complex, adenosine may be used for diagnosis and treatment. Other antiarrhythmics include procainamide, 20 mg per minute 4, amiodarone, 150 mg for given over 10 minutes, repeated as needed to a total of 2.2 G4 over the first 24 hours, and sotalol, 100 mg for over 5 minutes. SVT with aberrancy, if definitively identified, may be treated in the same manner as narrow complex SVT, with Finkel maneuvers, adenosine, or rate control. Irregular wide complex. A wide complex, irregular tachycardia may be atrial fibrillation with precatation. Patients with a wide complex, irregular tachycardia caused by precated atrial fibrillation usually manifest extremely fast heart rates, generally over 200 beats per minute, and require immediate electric cardioversion. Treat polymorphic VT with emergent defibrillation. A clinically stable patient with atrial fibrillation and a wide QRS interval known to stem from a pre-existing bundle branch block. Alternative methods for medication administration whenever possible. Acls medication should be given intravenously. Multiple studies have demonstrated that lidocaine, epinephrine, atropine, vasopressin, and naloxone are absorbed via the trachea. Doses for tracheal administration are 2 to 2.5 times the standard 4 doses, and medication should be diluted in 5 to 10 ml of sterile water or normal saline before injection down the tracheal tube. Post-resuscitation CRE. Important objectives for such care include optimizing cardiopulmonary function and perfusion of vital organs. Managing acute coronary syndromes. Implementing strategies to prevent and manage organ system dysfunction and injury. Termination of resuscitative efforts. Physician survey data and clinical practice guidelines suggest that factors influencing the decision to stop resuscitative efforts include duration of resuscitative effort minutes without a sustained sing rhythm, initial electrocardiographic rhythm of asystole, prolonged interval between estimated time of arrest and initiation of resuscitation, patient age and severity of comorbid disease, absent brainstem reflexes, normothermia.